Hey guys, John Adamson, the Rehab and Documentation Guru. I'm going to do a little driving while I talk to you. Let me see. Well, maybe I won't. I think I got time to just sit. And let me, therefore, turn off my car and have no background noise. Yes, I've shaved, in case you noticed. I didn't mean to shave this much. I took my growing epic beard down to basically a few days stubble. Didn't mean to do that, but yeah, my wife says it makes me look younger, so that's good. Anyway, I want to talk a little bit about vital signs. Two things. One is that please make sure you take vital signs on your patient. I'm going to go see a patient later on today, excuse me, who didn't have any diagnoses suggesting that normal cardiac monitoring needed to happen. And he had no signs and symptoms that would suggest high blood pressure, but you know where I'm going with this. But when I finally when I got to his house and he's not having any symptoms, I took his blood pressure, and his blood pressures were in the 180s over 190s over 120s over 130s, consistently between two different cuffs. And so I sent him to the emergency room. He didn't want to go 911. His wife didn't want him to go 911 either, so they drove. And I called ahead to the hospital to alert them to the issue. So anyway, take vital signs. You don't know when you're going to uncover something potentially dangerous for your patient. Even if you have a patient who's not normally having problems with vital signs, make sure that you measure and document them, especially in the older population. You know, it's normal for people as they get older to get just slightly hypertensive compared to a younger individual. The vital signs can tell you a whole lot of information on your patient. For example, you might have somebody that's normally hypertensive, they're taking a blood pressure med, they've had some recent events, you take their pressure, and like I had a patient yesterday, 92 over 58. So 90 over 60 is considered the borderline to hypotensive. And also this patient had a slightly irregular heart rate. So those were findings that I needed to report to the doctor. Asymptomatic at the time, but problematic nonetheless. I also wanted to cover real quick a few questions I always ask my patients in the home health setting when I suspect they might have cardiac issues, or if they have a remote history of cardiac issues. This is my device is too hot. I don't know why it's getting hot. Maybe I'll try unplugging it. Okay, so questions I ask my cardiac patients. Number one, how many pillows do you sleep with at night? There is such a thing as pillow orthopnea. Orthopnea is shortness of breath while you lie down, and so a good general rule of thumb is 1 or 2 pillows should be sufficient for most people. But if your patient's telling you that they're sleeping on 3, 4, or more pillows, then you ask them, well, what happens if you take away pillows? Does that make you feel short of breath? Some patients might not be able to quantify shortness of breath, but what they might be able to say is, well, I just feel uneasy when I'm lying flatter. I don't feel like I'm comfortable. I have to elevate some. It could be cardiac issues, and more specifically, congestive heart failure. Another question I ask them is, do you ever find yourself waking up in the middle of the night, suddenly short of breath, and you have to sit up to recover your breathing? That is what's called paroxysmal nocturnal dyspnea. It's also another sign of potentially CHF. By the way, I suffered from that condition for a little bit when I was quite a bit heavier and also pre-diabetic. So I was showing some very concerning signs for a little bit in my life. And fortunately, I haven't had an episode like that in a very long time. So I'm thankful for that. So I asked about that. The other thing I asked them about is if they get short of breath arising. That condition is called platypnea. It can be a cardiac sign as well. Also, of course, you want to ask, do you get positional dizziness? You know, you go from supine to sitting, sitting to standing. because as we get older, we do tend to struggle a little bit more with postural hypotension. Part of the issue with those of us that are aging is that we get more stiffness, less elastin is in our, especially our blood vessels, and so we don't get elastic recoil as well, and so you suddenly change position and your pressure drops because the elastic recoil that would normally occur to keep your pressure up, it just isn't there. So you are more subject to postural hypotension. So I always go through those with my older patients because you might uncover some specific issues that are concerning. I've covered other videos where I go into a lot of findings that, for example, skin issues you can look at to see if somebody has some cardiovascular issues. So I'm not going to repeat those now. But anyway, just some thoughts about checking vitals and some questions you want to ask your patient that are quick screening questions concerning cardiac issues. Hope you're having a great day. Take care and God bless.